All you, Sybil.
Great, thanks, Brittany. So hi, everyone. My name is Sybil Goulet-Stock, and I'll be presenting the results of our initial pilot evaluation of the MAPS that emerged during the COVID-19 pandemic on behalf of the CMAPS study team. So just a brief overview of the presentation. We'll start with a territorial acknowledgement, go through an introduction, and just talk about the study purpose and objectives, the methods that we used. I'll go through the results and then a quick discussion and conclusions of the study. So I would like to acknowledge and respect the Lekwungen peoples on whose traditional territory the university stands, where this work was completed, and also where I currently am living, and the Songhees, Esquimalt, and Wasanich peoples whose historical relationships with the land continue to this day. So we know that managed alcohol programs are a harm reduction strategy intended for individuals with severe alcohol use disorders who are experiencing unstable housing. Excuse me. MAPS provide regulated access to beverage alcohol, often together with housing, food, and other social supports. And though there are some critics of MAPS, the existing research does indicate that MAPS can be effective for stabilizing alcohol consumption, for increasing quality of life, and for reducing the consumption of non-beverage alcohol and alcohol-related harms. So there was a proliferation of MAPS in BC in response to the COVID-19 pandemic, with the goal of mitigating the risks of overdose, of withdrawal, and of COVID-19 infection among people who use alcohol in the context of the pandemic. So this study provides an in-depth description of the progress of 9 MAP participants in BC in this context of the COVID-19 pandemic. And the purpose of this research was to investigate whether MAPS could mitigate these risks. So these are the specific research objectives that we had. Was first to describe the characteristics of these new MAPS operating in the pandemic, and to explore whether entry into a MAP was associated with improvements in health, safety, and well-being, with reductions in service use, and with less hazardous patterns of alcohol use, and whether individuals were also better able to follow the COVID-19 related health and safety guidelines. And finally, we wanted to just explore what participants' goals related to MAP participation were. So this research focused on individual level data. We only had 9 MAP participants, but we really went in depth and have some rich longitudinal data with them. We did quantitative surveys as well as a few qualitative interviews. And one of the complicated parts of this research was that to collect the data during the pandemic, study recruitment was conducted in the MAP facilities, and it really was facilitated by the MAP staff who gave out cell phones and gift cards. They helped with recruitment, and they did all these things during routine contact, such as during alcohol distribution, to not increase the risk for anyone involved. So we did in-depth quantitative surveys at baseline, and then every 2 weeks for up to 3 months. And these included an assessment of health and safety, substance use, quality of life, physical distancing, and COVID-related behaviors, as well as alcohol-related harms. All of the measures were averaged across the 3 time points, so pre-MAP, MAP, and a few participants post-MAP as well. We did do 4 qualitative interviews where participants were asked about their experiences prior to and within the MAP, as well as goals related to MAP participation. And we completed a couple of qualitative interviews with MAP staff to help identify the characteristics of these new programs. So I'll only touch on this table really briefly. This shows some of the key characteristics of the 3 MAPs that participated in this study. And I just want to highlight a few key points. First, in one of the programs here, one of the eligibility criteria was that individuals needed to require self-isolation due to a positive COVID test or be waiting for a result. So it's possible that individuals in this program were only there for a few days, or they would come and go, as opposed to the other ones that were a little longer term. Next, in the modes of alcohol administration, we can see that 2 programs used a scattered site outreach model where the program staff delivered alcohol to clients at various locations, whereas the other program used a fixed site model where the individuals could come and get their alcohol on site, whether they were living there or not. So we had 6 men and 3 women who participated in the quantitative surveys. They reported consuming an average of 18.85 standard drinks per day prior to joining the programs. 8 of the participants met the audit criteria for alcohol dependence prior to joining the program, and all participants met the SADQ criteria for severe dependence. 8 participants were also unhoused prior to joining the MAP. So some of the results that we found. Overall, participants reported improved health, safety, and well-being, as well as an increased access to health and other services. This increase in access was likely due to the nurses and other healthcare workers who are part of the MAP staff and the availability of services on site. 5 participants reported an increase in overall health compared to pre-MAP, though 3 participants did report a decrease. Many participants rated the overall quality of their housing really high, and all participants remained housed throughout the course of the study. And importantly, all participants also indicated a decrease in the number of alcohol-related harms compared to pre-MAP. So here in this figure, we can see the decrease in alcohol-related harms experienced by all participants in this research. So this dark gray bar here indicates the number pre-MAP. On this axis, we have each participant and the number of harms. And we can see that the striped bar, which is the number of harms experienced while on the program, is always less than that dark gray bar. Yes, so in qualitative interviews, we also asked about health, safety, and well-being and harms, and participants all shared their experience of life prior to joining the MAP, where really they were focused on coping. Many of them talked about numbing pain with alcohol, and they noticed and noted the role of the COVID-19 pandemic in bringing them into the program. And they all shared their positive experiences with increased access to healthcare, the benefits to their personal relationships, whether with other participants or with the staff, and really the positive impact of the MAP staff. So participants reported a decrease in the average number of standard drinks consumed per day compared to pre-MAP, and no participants reported any non-beverage alcohol use at any point in the study. So here, this figure illustrates the average daily drinks and standard drinks. Again, we have each participant individually on the x-axis, and the number of standard drinks is the line, and the dark gray bars, again, are the pre-MAP numbers. And the striped bars indicate the number of drinks total that they had in the program, which included those provided by the MAP as well as outside drinks. The black bars indicate the outside drinks, and we can see a few participants continue to drink outside of the program, but overall there was a decrease in the average number of drinks consumed. So all participants did report drinking every day pre-MAP and while on the MAP. All drinking days were also high consumption days, which means that they were drinking 5 standard drinks or more per day. So 5 participants did report a decrease in the degree of alcohol dependence compared to pre-MAP, and 7 participants also showed a decrease in their experiences of physical withdrawal. It is important to note that participants did report a high frequency of other substance use while in the program. And in qualitative interviews, all participants outlined, again, the positive impact of MAP, and particularly on their drinking patterns. Though some are unable to provide specific examples of the program's impact, MAPs were only spoken about in a positive manner, and participants explained how the program provided stable access to alcohol, as well as a safe space for use. So we created a physical distancing and risk behavior scale to sort of measure physical distancing abilities, any risk behaviors, while in the program, and scores on this scale remained low throughout the study, but they did increase while participants were on MAP, which means that participants were better able to follow physical distancing and health guidelines while in MAP. And importantly, no participants contracted COVID-19 during the study. And in qualitative interviews, participants explained how the housing and regular servings of alcohol in the MAP allowed them to better implement some of these guidelines, particularly isolation. Participants also highlighted how the MAP allowed them to better isolate and be at home safe rather than in public collecting bottles or panhandling in order to purchase alcohol. So participants identified a few goals related to MAP participation, such as reducing their drinking, preventing withdrawal and seizures related to drinking. Interest in additional MAP services included interest in permanent housing, in job training and paid work, and some interest in volunteer opportunities. In qualitative interviews, most participants described the goals of decreasing their drinking, as well as maintaining stable alcohol intake over time. There were some other goals, such as saving money, obtaining independent housing, but really mostly participants highlighted the current advantages and benefits of being on the program rather than any future goals. So the results of the study are consistent with other research finding that MAPS can help unstably housed people with alcohol use disorders, particularly in the context of the COVID-19 pandemic. This research shows that MAPS can help reduce harm. While participants continued to drink high volumes of alcohol, they maintained steady drinking patterns, they consumed safely within their housing, and they experienced fewer alcohol-related harms. Additional research is needed to establish whether MAPS can facilitate long-term reductions in drinking in this new context, and whether long-term MAP participation is associated with any potential risks or harms. The continued high level of other substance use seen in this research was also a concern, and future research should continue to examine these patterns and should consider whether the influence of MAP site location has an influence on other substance use. An important finding of this research is the impact of MAPs during the COVID-19 pandemic. These new MAPs were developed to reduce the harms associated with severe alcohol use disorder, high-risk drinking, and unstable housing in the context of the pandemic. And this research shows how MAPs can address each of these potential harms during that context. And future research should consider the individual roles of the alcohol provision and management, of the housing, and of the different support provided by the different programs. There are a few limitations to this study. Future research ideally should include a larger sample with a comparison group of similar individuals who are not on the MAP. But again, there were a lot of limitations imposed by the COVID-19 health and safety guidelines, mostly to recruitment and data collection. Data is also typically collected in person with this population due to their experiences of stigma and mistrust, but overall the use of study provided cell phones for data collection was, I would say, successful. And we were still able to develop some relationships with the participants. It is also possible that some of the outcomes of this research are due to a comparison of life pre-COVID to life during COVID, rather than a comparison of life pre-MAP to life on the MAP, but there's nothing that we can really do to separate that out. So overall, the findings of this research add to the growing body of literature, evidencing the need and the impact of MAPS as a treatment option. This is the first study that includes these new programs using these different MAP models operating in the context of the COVID-19 pandemic. And though generalizable conclusions are not possible from this small study with only 9 participants, the findings are promising. Many harm reduction objectives of the programs were met. All participants remained housed. Most reduced their drinking or maintained a stable consumption pattern. And every participant experienced fewer harms. Most participants also expressed a high degree of housing satisfaction and highlighted their feelings of comfort and safety while on the program. So overall, this research does provide evidence in support of MAPS as a harm reduction strategy, particularly during the COVID-19 pandemic, and this supports the extended use of these programs beyond the duration of the pandemic. References. Thank you.
Great presentation. Super informative. I think we definitely have a little bit of time for questions and answers for folks. If people are okay, I'm going to keep recording because I think people really get a lot of use out of these questions if there are any. And if not, we'll just shorten the video. So if anyone wants to come off mute or use the reaction button at the bottom, that is the most useful way to get sort of in line to figure out who should speak next. Go for it, Jessica.
Thank you. I don't know if it's a question about related to, it is related, but I have some of the phones and gift cards still, and a lot of the paperwork that is related, and I don't know if it's too late to be added in to the study since it was done, but I still have some of I'm still doing it ongoing with all of our participants.
Yes, thank you, Jessica. I think that's great. I think that we've been in touch about that, and it is not too late at all to add the data. We're going to continue to analyze it and include it in sort of future summaries. This was just from the initial evaluations.
Perfect.
Hi, Sybil. Thanks so much for all the work on this report. It was really great to see, and really has validated, the kind of informal ideas we have around how the program is working here in Victoria. And, even looking now, we've been kind of running for a year past since the surveys were done, and to continue to see the success of those clients is really, it's really heartwarming, and I think just speaks to how effective the program is. So yeah, just there wasn't any big surprises for me. It was interesting to read about the clients who were accessing outside alcohol, which we definitely assume that there's a bit of that happening. And I think was happy to see though that there was like the trust there with the researchers to like talk about that. And I do think that that's, I don't know how we can address that more in terms of continuing to reduce harm, other than continuing to kind of build that trust and rapport with clients. Like we definitely have clients who always tell us when they access outside alcohol, and we are kind of continuing to kind of track to that. But it is a challenge with the scatter outreach model for sure to kind of be tracking to that.
Yeah, definitely. Thanks, Morgan. I know that continued consumption of outside alcohol can be an issue that other programs have reported, and different programs have different policies around that, and that can have an influence. But as long as you're tracking,
I would definitely have removed some clients from ongoing outside alcohol, especially if they're not willing to kind of try and work with us about developing a plan. And I think it's just the nature of the program and model, and will always be something that we have to kind of talk about. I definitely am interested I saw I just read your report this morning. I'm just getting back from holidays, and I'm really interested to look at the liver results, because we're kind of continuing to monitor that every 6 months, and we've definitely had clients who kind of continue to decline, and I think it is really hard to kind of tease out if that would probably be there kind of regardless, or if MAP is kind of negatively contributing to those folks. So I think that's kind of like a constant moral and kind of ethical dilemma that the nursing and medical staff kind of face when looking at like the health of the clients. But I think it still has been so important in letting people live how they want to live. And you know, we really see this work as palliative and supporting people to kind of make the choices that best fit with how they want to live their life. So it'll be interesting to look at kind of what that looks like too.
Yeah, thank you, Morgan.
Maybe I can jump in here too and add a couple comments on these really important issues. I think in our larger sample from CMAPS, we've clearly established that people are not dying as a result of being in the MAP. And I think that's important to keep in the foreground when I can totally appreciate on a day-to-day basis asking, as a nurse myself, asking that ethical question, am I doing harm or am I doing good? And I think one thing we maybe haven't looked at enough is around kind of goal setting and potentially, and I'm talking about us, the researchers, goal setting and motivational interviewing and how those goals are set, because many of those individuals would die outside and it would be a much worse in many cases, I think. But how do we put that into context? We need to know the client's goals and motivations, right, around it. And, you know, we've been doing a lot of work in CMAPS in this next phase around cannabis and the role of cannabis as well as the harm reduction intervention. And so, you know, we've got quite a lot to, I think about in terms of what we might be able to offer clients going into the future. So those are just some thoughts around that. And I think it's hard, though, to keep focused on the bigger picture sometimes. And if we can help with that, we'd love to do that. That's kind of the one kind of comment I wanted to make. And then the other one, and Sybil, thanks so much for doing such a great job of presenting all of the findings. And, you know, what really strikes me over and over again is even though we've got different models here that we're delivering managed alcohol, we're actually getting a lot of the same outcomes. Less drinking, fewer harms, more connections to services. So I think even though the sample's small and obviously we need to do more work, it does, and it aligns with work that others have done, like Shannon, the work that you've done. It aligns with, you know, some of the things I did in Nova Scotia during COVID, because those are kind of the three sites where we've got some literature. So I think it's important as well to recognize we're replicating the kind of same pattern, even with different models. I think that's a pretty important finding of it. So just throw out those thoughts.
Well, and I think like it was a very small sample, and like we had lots of other participants now in the program, and I was interested to kind of look at the goal stuff too, because I would say like our perception of some of the clients' goals are a little different than what the survey results showed. And like I would say looking at the data now, like every client that we have on the program has had a significant reduction in standard drinks. But it's taken like over a year for some of those clients to be ready to like make those changes. And I think it just speaks to, like you said, that the work of the motivational interviewing and that relationship, and change takes time, right? So it would be really interesting to kind of look at a more longitudinal model for some of these folks, but you know, that takes a lot of time.
I think there's a question in the chat box from Nick related to other map models that we were seeing in the study.
Hi, Sybil. Nice to see you in this context as well. Yeah, I put a couple questions in there. I don't know if you saw the questions or if you're able to share a bit more. And the second sort of chat box thingy is kind of aligned with the first, but you may not actually be able to answer the second line of questioning, depending on what the model was for the first one. So by all means, I'd love to hear more. And apologies if I missed this in one of the slides, if you'd already said it.
Sure. So I didn't touch too much on the different map models because there are a lot of differences, but I can pull up the slide again with the table that sort of shows some key differences. Let me just. So I don't know how well you can see that, but we looked at the programs based on these different criteria of program goals and eligibility, whether food and accommodation was provided, mode of alcohol administration, funding for the alcohol supply, money management, primary care services, and any additional connections that were provided by the programs. All of the programs were BC based for this study. And a lot of the eligibility criteria for the programs included the things that we see often of a history of long-term heavy alcohol use, histories of withdrawal and seizures, harms experienced related to alcohol use. The only really different one was in that one program that required participants to need isolation because of COVID-19. And then some programs provided food, others just snacks, but there was always a connection to meals somehow, and the primary care services, things like that as well. There was always a connection to nurses or other primary care services, different supports and things in some programs and not in others. As for your other question, which was about the criteria for the inclusion in the study, was very, very broad. We initially had some ideas of, including only people who were quite new to the program, trying to get them at baseline in order to do that comparison really of pre-map, initial map, and later. But with all of the limitations imposed by the pandemic, the staff who were working these programs, who were, focused on providing the service and were overwhelmed with all of those things, it was difficult to sort of facilitate that. So we accepted anyone in the program who had been participating in the program, who was interested in participating in these interviews and surveys, and who could provide consent for that.
And then,
Sorry,
go ahead, Nick.
That's amazing, Sybil. And I'm interested in the note that you gave around food as well, because in the creation, like in our clinician-led model here at Island Health, one of the things that we're like when we write an order set, we need to consider food security and the different things that say might be ordered for lab work, and longitudinally what things might be able to be monitored. So food security, of course, alongside the other related harms, is important. And so thanks for noting that. Sorry, Bernie, I didn't mean to.
Oh, no, not at all. I'm glad you brought up the issue of food, because I don't know if some of you have seen the harm reduction information that EDGE, Eastside Illicit Drinkers for Education, produced. And it's got a really nice focus on food as a harm reduction strategy for people who are drinking. Brittany, are you able to post a link to that in the chat? Because it would be great information for like programs, like it's real practical guidance about how you can, when to, to prepare food in advance, to what kind of food to prepare. It doesn't address the food security issue, which is the bigger, but it's a really nice practical set of guidance around food. The other thing I was going to mention around eligibility is the like as Sybil described really well, the eligibility for being in the research was being in the program essentially. And so for the programs that the eligibility was really aligned with some of those policy directives that I posted. But the one that was really, I think, different among the programs was whether or not the person had to be suspected or caught positive COVID. And that really was determined by the provider of the service. And that's why, you know, when Sybil did her overview, she highlighted that one because, and I just want to say a big shout out, and it's probably because I know Island Health Program the best, is that, you know, that and other programs never tied it to COVID, specifically because whether people had COVID or not, the harms were there for people because they couldn't panhandle, they were having trouble getting alcohol, and those harms were just escalated. So not tying it to COVID really aligned with the guidance as well as the research. And I recognize that, you know, things happen differently in different programs, and in some cases those decisions were probably tied to resourcing as well. And I don't know how many of you saw the excellent webinar that Nicholas and Morgan did a while ago, and the careful thought that kind of went into thinking about MAP far before COVID. Like, I think we were presenting, Nick, you were presenting to the executive, and I was speaking with the executive long before COVID about rolling out MAP. So there's a history there that I think is quite important. So just adding those thoughts.
Great. Is there any final questions that folks have? I think it's a smaller group today, so we may not have. And I think a lot of people are maybe aware of some of the ins and outs of this research since they were part of the participant sites. Okay, well, I'll take that silence as Sybil did a fantastic job presenting everything, and everyone understands everything you could need to know about this specific research project. We'll be storing the recording on our cmaps.ca, and we'll also have it on our YouTube page. As we've previously mentioned, thanks Bernie for sharing the operational guidelines. The national guidelines should be coming out sometime in the fall. We're not sure when, but they're out for review right now and editing and all that stuff. So thanks everybody for coming, and we will get these out to you as soon as possible.